Hello and thank you for joining us for today's Feed Your Mind webinar. This series is part of Age Friendly Arizona. We are a network of communities dedicated to connecting older adults with people of all ages. Age Friendly Arizona is supported by partners statewide and beyond, including AARP-AZ, Virginia G. Piper Charitable Trust, and grant makers in aging. Please check www.connect60plus.com for news about upcoming webinars and for recorded webinars that have aired previously.
Well, good morning, everyone. My name is Lori Nisson. I'm a licensed clinical social worker, and I work for Banner Alzheimer's Institute. And I've had the pleasure of working with many people and families who are living with Alzheimer's disease over the last 20-some years. So I'm really pleased to be able to share this information with you. We're really going to be covering this topic of behaviors, expressing what words cannot. And so really my lens is that I believe that most behavioral and communication changes that occur in somebody with Alzheimer's or other dementias can really be minimized by employing a lot of behavioral approaches. And I think those are first and foremost in successfully managing the care of people who are living with dementia. So really what I'm hoping that we'll cover today is to identify some of the common behavioral changes that you might see in a family member or person that you're caring for professionally. Really take a look at some of the common causes or triggers of behaviors, and really help to learn some effective strategies in helping you mobilize and minimize some of the behavioral changes that you might see in somebody with dementia. And then kind of know your limitations. So I'm a behaviorist, I'm not a pharmacologist, I don't prescribe, and I know that most challenges that I face in communicating or looking at minimizing some of the behavioral challenges that we see in folks with dementia can be modified by the environment or my communication or looking at other factors. I know that there are certain occasions when it's really necessary to call upon my medical professional partners to really mobilize those resources. So we'll cover that as well. So I think it's important to really start with a sensitivity. So really, I think it's important for us to really kind of use the golden rule here and think about what it might be like to experience dementia ourselves. So dementia really affects somebody's ability to manage their environment, communicate effectively, and to behave conventionally. Behavioral changes are part of the disease process. I often hear family members say things like, well, my mom has always been kind of a manipulative or difficult person, but we need to put those thoughts in the past and recognize that what's happening here as somebody develops dementia and progresses is that these behaviors are really being driven by the cognitive changes that are happening in the brain. So typically they're not volitional, and the person can no longer function at their previous level. So I think it helps us to redefine our expectations of that person. And it really requires us as caregivers to anticipate needs. And so while some of these communication changes and behavioral changes can be very frustrating for professional and family caregivers, we really always want to remember that this is the disease and to implement care with compassion and empathy. So behavior has a purpose, and it's really signaling an unmet need. Behaviors are triggered by an impetus, and our role, one of our many hats, is really to be one of a detective. Our goal is to really figure out what causes the behavior and then try to step in to alter the pattern or even prevent the behavior from happening again. And what we learn is that by shifting our own approach, we can have a more successful outcome. So it's important to know that about 80% of those people with dementia will experience some behavioral disturbance somewhere in the course of their disease. So when we think about the disease and we think about dementia as really an umbrella term, of course, underneath that umbrella are different types of dementia. Alzheimer's is the most common type. And so what we see is that the disease is progressive, and over time, cognitive, behavioral, and functional changes worsen. So when we think about the stages or phases of the disease, there's early, moderate, and late. And so kind of in the moderate stage of dementia, Alzheimer's or other dementias, we often see the most behavioral changes. However, in some of the other types, like Lewy body dementia or frontotemporal dementia, we might see some of those behavioral changes more prominent earlier in the disease. What I've found in my work, in having the pleasure of working with many people who've experienced cognitive disorders or dementia, in the early stage we often see a lot of emotional symptoms as the person, depending on their awareness of the disease, is often experiencing a lot of loss, a lot of frustration with tasks that used to be very simple or easy for them, and often depression or anxiety as changes in the brain occur, and also their ability to navigate the environment is becoming more and more difficult. And you've probably heard about that pop psych term called sundowning, which really means that as the day progresses for somebody with dementia, those symptoms worsen. As the person becomes more fatigued, we see more behavioral changes as the day progresses. So we know that Alzheimer's and other dementias are progressive. As the disease progresses, behavioral changes follow, and functional decline often parallels. So what I mean by that is, as memory fades, the person's functional abilities also decline. So many or most people who are in the early stage of Alzheimer's disease have been very functional. Maybe they're ambulating quite well, but as the disease progresses, you see that their gait, their ability to walk is declining. So we start walking independently and then need a walker and then progress to potentially needing a wheelchair. And what's difficult about the disease is that what we find as a solution to the problem often needs modification or change as the disease progresses. So I think really the key to managing difficult behaviors is being creative, being flexible, being able to shift our thinking, and to step out of old patterns of communication, which sounds easy, but if you're someone who has known the person for 10, 20, 30, 40, or 50 years, and you've been communicating the same way, especially if it's a loved one, this is often more complicated than simple. And so I think really each day and each moment can really be different. And when we find an intervention that is effective on a Monday, it may not be effective on Tuesday or even Monday afternoon. And so we really have to be flexible in our thinking and creative in finding solutions. So we think about behavioral changes. What we're really thinking about is the fact that dementia really affects memory, right? But it also affects emotions. It affects somebody's ability to carry out daily living tasks. Things that used to be very simple now become complicated. It affects their ability to navigate the environment. And of course, language and communication is also affected. And so as the world becomes more complex, handling simple changes and mild or moderate stressors becomes really complicated and overwhelming for that person. And so as the disease progresses, making sense out of the world becomes more and more difficult for that person. And so that's why it's really important for us to kind of understand the basis and the framework for dementia so that we can understand that really behaviors are not meant to be difficult or challenging or volitional. Really, behaviors often replace communication, as the person can no longer verbally communicate in the same way. So behaviors communicate someone's needs, feelings, and messages. Sometimes they're messages with very personal meaning. So Often behaviors communicate things like pain, comfort, distress, sadness, angst, or even anger. So when you think about some of the behavioral changes you've seen in somebody who is living with dementia, you may have seen someone who seems paranoid or suspicious, maybe someone who's wandering, maybe even somebody who seems confused or argumentative, or maybe it's more emotional. There's depression, maybe anxiety or agitation or an inner restlessness, or maybe even mood irritability. So before you jump to conclusions, before you get defensive, really kind of take a step back, take a deep breath and say, is this behavior really a problem? And if so, whose problem is it? So as a family caregiver, is it when your person is wearing the same clothes day after day or gets really attached to that same pair of navy blue pants, think to yourself, is this really a problem? Is it my problem? Or is it a problem for the person with dementia? And so I think that really kind of helps guide the way we intervene. So what we're really looking for here is that if the behavior is problematic for the person with dementia, meaning that it triggers a signal to us that maybe they're uncomfortable, distressed, or downright upset, then we maybe need to shift our approach. If the behavior is just making us uncomfortable, maybe we need to be more self-aware. So if you've been in a relationship with a partner or with a son or daughter or with a parent, you know that you can't pick every battle, right? You have to let some things go, and that applies here. So when we see a behavioral change, we're really looking here, we're putting on our detective cap and our lens and using our microscope to think about, why did this behavior happen? What's changed for this person in the situation or even in their environment? And what might he or she be trying to tell me? And once I think about that, the goal is to really eliminate the trigger to help our person navigate more effectively. Sounds simple, but it's a little bit more complex than that. And so I try to break things down a little bit for you here, thinking about some of the environmental triggers that might trigger behaviors in somebody with dementia. Often it's a misperception. So is the person misperceiving the environment? For example, does a rug in front of the door appear to be a black hole to them because they're having visual spatial changes? Is there a change in routine? We kind of take for granted that we have a very busy workday or a very busy family life, and when obstacles present, we just shift our approach, we shift our day, we shift the activity, and it's no sweat. But for somebody with dementia, a change in routine is a really big deal. So a change in daily structure or a change in caregiver can trigger a lot of behavioral changes. The holidays are a great example of that. So you have your daily structure. For somebody with dementia, maybe you kind of do the same thing pretty much every day, which is great. It allows them to get a rhythm. But then the holidays present, and there's family in town, or there's lots of food, or maybe even lots of decorations in the environment. That causes a lot of stress for somebody with dementia when there's change. Or providing care. So especially hands-on care, helping someone who needs really help with bathing or dressing or even brushing teeth, can create a lot of behavioral disturbance. In fact, a lot of behavioral changes occur especially when we're providing care. And if you've ever cared for somebody with dementia, you know that things like bathing can create lots of behavioral disturbance. And why is that? Well, it puts us as caregivers in a very intrusive position. And if you're trying to use the golden rule here, or empathy, and put yourself in somebody else's shoes, I mean, I don't know about you, but this morning I got into the shower by myself. There was a lot of privacy, and the door was closed, right? But as somebody progresses through dementia, and as we said, declines cognitively, they're also declining functionally. And so we're needing to provide hands-on care as that person is no longer able to dress or bathe on their own. And so putting yourself in their shoes, I mean, if someone is helping you with bathing, think about how that feels just from a privacy level. So there's lack of privacy, there's lack of control, right? I'm not able to decide when I take a bath or where I do that. You're telling me, or you're dictating that. And then there's lots of other privacy issues. Imagine how it might feel if you were living in an assisted living center or even at home, sitting in a shower chair, in the middle of a shower room, and someone's trying to help you. You're naked, you're cold, you're feeling very vulnerable. The environment itself can create lots of behavioral disturbance. Maybe there's too much noise. If you've ever been in a long-term care community, there might be other residents who are calling out or making a lot of noise. There might be a loud television on in the background. There might be someone speaking on the overhead speaker. And so that can cause distress to somebody who is feeling overstimulated with too much noise, too much action, too much happening. On the reverse side, too little stimulation can create agitation. So imagine if you're somebody with dementia who's in the moderate, maybe even in the advanced stage of dementia, you're no longer able to walk, so you have a care provider who's helped you get ready for the day, helped you get settled in your wheelchair, and sat you in front of a television or a nursing station or a common area, and you've been sitting there for a large part of the day. Maybe the assisted living center's recreation therapist called off for the day, or maybe they don't have a lot of activity stimulation because they're so busy providing care for other residents. And imagine you're sitting at that station in the same position for 4 or 5 or 6 or 7 or more hours without anyone talking to you or having any level of activity at all. Might you feel agitated, cranky, frustrated, and yell out by the end of the day? That would be an obvious behavioral response, right? So I think it's this fine balance of creating enough activity with rest periods, but also keeping that person stimulated. Because what often happens is we think to ourselves, well, that person can't do the same activity they once did. They can't play bridge the way they once did. They can't read a book the way they once did. So they can't do it. And so we're really focused on the things they can't do rather on creating meaning and purpose for them day to day, which is still a very strong and high possibility. So other common triggers that we see are more physical in nature. So maybe it's just the cognition that I'm having a very confused moment. I'm feeling very lost in my environment. I'm feeling lost in what I'm supposed to be doing. Maybe it's actual physical pain or illness. Maybe I'm having arthritis and I can't share that with you. And so instead, I'm expressing it through actions. Maybe I have a urinary tract infection or a pneumonia or even constipation or a virus. And I can't say to you, hey, my chest hurts, or I feel like I have to urinate, but I can't get it out. And so instead, I'm feeling miserable. And maybe I think I'm communicating that to you, but you're not understanding me because I can't communicate effectively through language. And so instead, I'm just sad and crying a lot, or maybe even striking out at people when they're trying to approach me. Maybe there's a side effect of a new medication, or maybe I've just had surgery. And so some of this might be related to what we call delirium, where there's an abrupt change in someone's mentation. They might even act psychotic as a result of having a urinary tract infection or pneumonia that's not being treated. And so that's difficult for us as care providers, again, because a person can't say to us, hey, I'm having back pain today, get me some Tylenol. And so we're wondering what the activity or what the behavior is all about, and we're having a really hard time figuring it out. There was a dementia behavioral long-term care program that I used to be the clinical director of. And we had a gentleman who lived in that program because he had a lot of behavioral disturbance through the course of his dementia. And other assisted living communities were really having a hard time handling it. So he came into our program, and within 6 months or so, we really saw no behavioral change at all. I mean, he really settled in, got to know the staff, they kind of got to know the triggers of his behavior, kind of got to know his routine, what he enjoyed doing, and he did quite well. And then all of a sudden, felt like out of nowhere, he started striking out at staff. And people were wondering, what's different here? We haven't had a change in care providers, we haven't had a change in structure, haven't had a change in family visits. Couldn't figure it out, didn't seem to have a temperature, just really could not figure it out. So weeks went by, and one of the CNAs who was providing care for him and helping him brush his teeth and provide oral care in the morning noticed that she was helping him with his toothbrush, and he screamed out in pain. And so we got one of the mobile dentistry groups in to evaluate his condition and found out that he had a tooth that was infected. So shame on us 3 weeks later for figuring it out. Once he had dental care and unfortunately had to have that tooth removed. Once it was resolved, he actually healed well and kind of went back to baseline, no behaviors. But it was really hard for us to figure out because he couldn't say, hey, listen, my mouth is hurting, my tooth's infected, I need help, I need to see a dentist. And so we had to rely on figuring out, being a detective, and figuring out what was happening. Often it's unmet needs. Maybe the person has been sitting in their wheelchair a while and they're really uncomfortable and they can't say to you, hey, I need to be repositioned, or I want to get the heck out of this chair. Or maybe the person is just really tired and they can't say, I'm tired, I'm restless, I'm irritable. Or maybe the person's hungry or thirsty, and we don't know it. Maybe we've been putting water by their bedside, but they haven't been drinking because they don't remember to do that, and they're becoming dehydrated. Or maybe the person is walking around and pulling at their belt buckle. Do you think that might signal that they need to use the toilet? Maybe they can't find it, or maybe they can't do that on their own. They really need someone to help them navigate. It could just be a general discomfort, dissatisfaction, or even distress. So when we think about the phases of dementia, and again, we're talking about different types of dementia, maybe Alzheimer's disease, which is the most common type. Maybe we're talking about Lewy body dementia, which is the second most common type, kind of a hybrid between Alzheimer's and Parkinson's, if you will, experiencing movement challenges as well as memory challenges. Or maybe it's a vascular dementia, the third most common type of dementia, which is typically caused by strokes or TIAs. Or maybe even a frontotemporal dementia, which is often triggered by, often demonstrated through lots of behavioral changes rather than necessarily cognitive changes. So when we think about these phases of dementia, we're really looking at early, mild, or advanced stage. So maybe in early stage, we're really looking at more apathy, depression, anxiety. As the person's having more difficulty with language. Maybe in the moderate stage, it's really more the hands-on care and becoming assaultive when someone says to them, hey, I'm going to help you get ready for bed. And because the short-term memory is so short, by the time you approach me and start removing the buttons or opening the buttons on my shirt, I've already forgotten who you are and what we're supposed to be doing. And it appears to me that you're not listening, so I might strike you. And then in the late stage, we're really not seeing so much resistance, but people who are retreating and withdrawing more. And so because that person is often less active, less communicative, and less mobile, they're having a lot of more advanced discomfort. And so this kind of gives you a breakdown, this chart here, of what things you might see as the disease progresses from a behavioral standpoint. So what things can you do or think about in the care of somebody with dementia to prevent some of the behavioral changes from happening? We really have to think about implementing rest periods, but we certainly don't want the person sleeping all day, right? Because as a consultant in long-term care for many years, I would often see situations where someone was inactive during the day, sleeping or dozing a lot, and then not sleeping well at night. And then seeing care staff who were calling or reaching out to the physician or medical provider to say, hey, this person needs a medication to help them sleep. When instead, really that person needed more meaningful activities to be more alert during the day with some small rest periods so that they could sleep better at night. Reducing a lot of external noise and distraction is going to be helpful, because that person's ability to filter out multiple noises or things or stimulation at one time is going to be difficult. I had the pleasure several years ago of working and counseling with a woman who had mild cognitive impairment and then early Alzheimer's disease, and then moved into moderate and advanced. But early in the disease, she was very aware of her memory loss, and she shared a lot of these situations that were very difficult for her. She said, for example, that when going for coffee seems like a relaxed, pleasurable activity, for her, it was really a situation where she was trying to focus on one person's conversation when there were multiple conversations going on in this coffee shop, lots of noise. She was working really hard to listen to questions that someone might be asking her and answer them appropriately and act normal. And so those situations were very overwhelming and stressful for her, while that might be something that's really easy and comfortable for you. So we're really looking at reducing noise and eliminating a lot of external distractions, particularly when we're trying to focus on an activity or focus on communication. We want to have, as best we can, a predictable daily routine with flexibility to change that if the person seems uncomfortable or distracted or just is having a bad day. We want to offer meaningful activities. Something that really doesn't change throughout life is that we all have to have a sense of purpose. And so we have to offer meaningful activities. We want to step into that person's shoes and think about what that situation, environment, or experience might feel like to them as we're evaluating how to prevent some of the behavioral changes. And we want to shed previous expectations. A wise caregiver in one of our support groups said, whenever I run into a roadblock in my life, whether it's in my relationship with my husband or in caring for my dad who had Parkinson's disease and also dementia, or in my work life, whenever I hit roadblocks, I think to myself, I need to redefine my expectations. So while the person can no longer play a board game in the same way he or she did in the past, or carry out a conversation the same way he or she did in the past, it doesn't mean we eliminate the activity. We have to modify it. And we have to shed previous expectations. And we have to focus on small successes. So how do we really want to approach communication and behavioral changes in somebody with dementia? We want to find and address the cause or the trigger of the behavior. We want to really keep the nonverbals in our own approach and in the environment calm. We want to keep our communication slow and simple. And for some of us, we have to work at it. So I'm from Chicago originally, so we walk fast, we talk fast, we do everything fast. We have to slow things down. So we want to keep communication simple, and we want to slow things down. We want to focus on the strengths of the person. And we want to really focus on addressing the emotion. So if the person seems distressed, we want to slow down. We want to pay attention to what emotion they may be demonstrating or displaying. And no matter if we've done anything wrong, we want to apologize. We want to reassure them. When the going gets tough, we want to just calm the environment down. So as the day progresses, if the person is feeling distressed or seems overwhelmed or there's too much stimulation, we want to calm the environment down. So we might want to turn the lights down a bit. We might want to play some soft music. Or we might want to just turn everything off and have some silence or quiet. We want to look at what's triggering behavioral changes and really remove those triggers. We don't want to argue with someone. So we have a saying at Banner Alzheimer's Institute, you're never going to win an argument with somebody with Alzheimer's or another dementia. So instead, we want to agree with the person, We want to apologize, even if we've done nothing wrong. And then we want to distract or even defer the situation. So I had a gentleman who I was working with who was really kind of struggling with this. He and his partner had been together for about 30 years, and they had lived in Arizona for about 15. They had come here from Iowa to Arizona to retire in a nice warm climate. And his partner had developed Alzheimer's disease and was moving from the early stage to the moderate stage. And his care partner, his partner of many years, was really struggling with the fact that the person with dementia, John, had started saying to him, I really want to go back to Iowa. And the caregiver, his partner, was really frustrated by that. He would say, what do you want to go back to Iowa for? We haven't lived there in 15 to 20 years. Nobody we know even lives there anymore. Anybody we knew that lived there has either moved somewhere else or is dead. And so that didn't go over well. So his partner would get very upset, leave the room, go into a bedroom, and slam the door. And so he came to me and said, I'm just telling him the truth. I don't understand why he keeps getting so upset. And so we really tried to employ this approach. Don't argue with him. Really just try to agree, apologize, and distract from the situation. So the next time his partner said to him, I really want to go back to Iowa. He said, that's a great idea. We haven't been there in a long time. We really had some beautiful times there. Do you remember when we lived near the lake and we would get up in the morning and we'd walk our dog along the lake and we'd watch the sun come up? It really was a nice place. It's winter there right now, though, so I don't think now might be the best time, and it's going to take me a little while to get that travel arranged. But I'll look into it. In the meantime, let's head out to that luncheon that we're supposed to go to, and we'll look into travel plans later. And that approach was much more successful. So what do we do that often inadvertently escalates behavior? Those of us who have had the pleasure of working with or being around people with dementia, sometimes we think we got this and we use an intervention or use a communication technique and things go really well. But all of us have situations where we think, I just stuck my foot in my mouth and I made things worse. Why is that? So some of the things that often make our communication and make behavioral changes worse in the person with dementia are things like correcting the person, trying to reason with them. So I'm going to get a caregiver to stay with you because you can't be left alone. It's not going to go over well. Arguing never leads to a positive outcome. Trying to reorient the person, so something we did in the early 90s that we thought was going to be effective in long-term care was telling someone the date, time, and place over and over during the day. Was that effective? Not in the least, and it's not important. Always telling the truth and nothing but the truth often is not helpful either. Over-explaining, and I think I'll stereotype here and say that often women are really bad at this. We feel like we have to give an explanation for everything. And that just confuses the person with dementia. They can't retain all those details, it's not useful, and it's kind of a waste of energy. Exposing our own frustration or anger, so scolding the person, or pointing our finger at them, or having unrealistic expectations about how quickly they can get ready or manage a task, and then setting them up for failure. Or trying to retrain somebody. So I had a family caregiver that I worked with for a period of time who was often testing his mom. His mom was in the moderate stage of dementia, and he would often test her about the names of grandchildren or what she had done during the day. And you could see very clearly that every question he asked, she was getting more and more frustrated and angry and annoyed. And so when he and I spoke afterwards, I kind of asked him, what were you thinking there about testing her, and what was your motive? And he said something I thought was really poignant. Use it or lose it. And so I think we have this idea in our culture that we're going to retrain or get someone to remember a detail because we're asking them to, when all it serves is frustrating them, and upsetting them. So what can we do to actively de-escalate a situation? We want to provide plenty of rest periods. We want to alternate with periods of activity. We want to look at past activities and sources of pleasure for that person and try to modify them and shorten the duration so that the person can still enjoy them. And not focus so much on success, if you will, but the actual process, that person's pleasure or enjoyment in the moment, and that is really the success. Exercise can often be helpful in reducing levels of agitation or anxiety, depending on that person's ability. Certainly, we're not looking at running a marathon here, but if the person can still ambulate, taking a short walk in the morning can be helpful in reducing their level of stress, and probably yours as well as a care partner. Trying to maintain a regular routine as much as you can, but allowing for flexibility. Those techniques we talked about earlier, agreeing, apologizing, and distracting from the situation. Modifying our reactions, understanding that this is the disease, and increasing our own patience is going to go a long way. And just accepting our person, who they are now in this moment. So often caregivers, particularly family caregivers, we get swept up in thinking about the loss of who this person was in the past. Or maybe thinking too far ahead and worrying about what's going to come next and how we'll handle that, missing out on who this person is now, their successes, and being in the moment. Because this is a progressive illness, and so this is the person's very best day. So we have to accept who they are in this moment and really look at the activities that they can do and enjoy now. So if someone used to enjoy golfing but can no longer golf 18 holes, can he or she golf 9? And if that's not a possibility or that seems overstimulating or too much, can the person just putt or hit a bucket of balls? If not, could the person still maybe walk the golf course, the periphery, with a care partner or a friend? And if that's too much, maybe could they just have lunch in the clubhouse, kind of be around golf and an environment that's always brought them joy? So I think it's really looking at activities the person used to enjoy and trying to modify them. And maybe even look at activities that they haven't done before that could bring some new pleasure to them. So there was a gentleman who was sharing with me that he really enjoyed dancing. And he and his wife had been married for a number of years, and she had always been a very self-conscious person. And when he wanted to dance with her, she would say, "No, that's okay." And so as a result, they never danced. As she developed dementia and she was less inhibited, they began dancing in their living room in the afternoon. So it was an activity that created some intimacy between them, an activity they could both enjoy and find pleasure in. So one of my colleagues at Banner Alzheimer's Institute did a literature review and really focused on some study interventions of things that could be employed to really help modify or reduce agitation and other behaviors. And what she found was that massage or therapeutic touch was very helpful. Playing someone's preferred music, whether it was live, through a speaker, or even headphones, was very helpful. The use of aromatherapy or scent to reduce agitation, like lavender oil, for example, or other things that came up in the literature were things like lemon balm or melissa leaf oil that could be put on a pillow or even a diffuser. The sounds of nature, so birds chirping or ocean waves or even white noise, could relax someone when they're feeling overwhelmed. Pleasant activities, things that the person enjoys, capitalizing on maybe the early part of the day when they may be most alert and most comfortable. Interaction with pets has also been found to be very therapeutic with most people, and that's why you often see therapy animals being employed in long-term care settings. Simple social interactions or even use of photo albums or a photo slideshow to reminisce about the past or to show pictures of grandchildren or animals. Using someone's favorite foods like ice cream, for example, when they're feeling stressed, or even physical activities, as we were talking about earlier, walking or even using a simple pedal bike to help that person reduce their level of stress and stay physically active. So let's think about some opportunities for us to apply some of these principles that we've been discussing. So we have a situation here where a daughter's caring for her mom. She's gotten some respite and returned from a trip to visit her other family out of state. While the daughter is preparing dinner, her mom comes in and announces that she's really tired and she is leaving to go home and she's out of here. So think for just a second or two about this scenario. Think about, is this a problem? Why might it be happening? What could you do to intervene? And as the daughter, what could you do to try to prevent this from happening in the future? So I think we've covered the fact that change in environments or caregivers can often trigger behavioral change if the person's really having a hard time navigating the change. Even though this daughter appears to be the primary caregiver, she's been absent for a while. And this return and change can often trigger distress in the person with dementia. The daughter could say something like, hey, I could use a walk too. Let's go. Maybe take a walk around the block. Go grab the mail. Or maybe she could say, going home would be fine. I'd actually be pleased to get you a ride. In the meantime, I'm about to cook this delicious dinner. Why don't you stay for dinner? And we'll try to find home afterwards. And would you mind helping me by setting the table? So I think this could be a problem if the person with dementia is now, walking around the neighborhood on her own, or is getting upset. Or it could be a problem if the daughter says to her, this is home, Mom. That could be upsetting to her. But instead, kind of going along with where her mom is going to be a much more effective mode of kind of joining the journey. It's important for her to, as best she can, keep routine stable, and also expect that when she leaves to get some respite, that when she comes back, there may be some behavioral signals with this change in caregiver. It certainly doesn't mean that the daughter should avoid respite. It just means that she should be aware that some of these behavioral changes can occur as a result of her absence and then her presence once again, and to not personalize it, not get angry at her, not scold her, but instead go along with it. So often there are symptoms or behaviors of suspiciousness or even false beliefs. So we have a husband here who's been caring for his wife at home. Recently, whenever the husband leaves and returns, his wife has accused him of cheating on her. So is this a problem? Why might it be happening? How would you intervene if you were the spouse? And what might you do to prevent it from happening in the future? So I think these situations are often very painful and difficult for spouses. Assuming here that this husband's been loyal to his wife and he leaves to go take care of an errand, reminding him that this is the disease, it's not his wife. So becoming defensive here is not going to be useful. Probably her orientation of time is affected here. So even if he was gone for a short period of time, maybe he told her where he was going, it might feel like a very long time to the wife. She can't remember where he said he's been, so often the brain fills in the blanks. So being gentle, light, and affectionate in this situation could be really helpful. So honey, you are and have always been my only true love. I would never think about anybody else. I missed you while I was gone. So giving a hug and a kiss could be really helpful in kind of de-escalating the situation. Often, leaving a brief note or letter before leaving can be helpful. As the person's short-term memory is short, if he or she is alone, the note could be posted in a place where he or she would look frequently, or this may often signal a trigger that maybe being left alone isn't a good idea, and there should be a care partner or a respite worker that's going to be with that person, or a neighbor or a friend, while he takes off. And that person can gently remind her, oh, he just went to Safeway, he'll be back soon. Or show the note that he's left her, telling her where he is and that he'll return shortly. We talked about resistance to care often being a trigger to behavioral disturbance. We have a woman who's caring for her sister. She notes that her sister isn't bathing regularly anymore and is very frustrated. She confronts her sister and says, hey, you haven't bathed in a week. And her sister gets very defensive and says, hey, I've already bathed today, and I certainly don't need your help or you telling me what to do. Is this a problem? Why might it be happening? What should her sister do in order to intervene? And what could she do to even prevent this situation from happening in the future? Well, one thing she could do is go about paying attention to semantics. So how she says what she says is going to be very important here. So if her sister really hasn't had a bath in several days, she might want to think about the language of bathing, the timing, and even the setting for bathing are going to be important. So maybe it's not telling her you need a bath or a shower, but offering or inviting her for a spa treatment, a massage, or even just an opportunity to get cleaned up might work better, might be less intimidating, might be less threatening. Remembering the time of day. Is the person with dementia someone who's always gotten showered or bathed or cleaned up in the morning? Or has it been the evening? Maybe she's someone who's always had her hair done once a week and never washed her own hair. So being aware of those dynamics are really going to be important. Maybe even offering a reason for bathing, like we have a luncheon to go to, or a doctor's appointment, or the grandkids are going to be visiting. Or maybe it's time for us both to get cleaned up. Maybe we could get cleaned up together, or would you like to get cleaned up or showered before me or after me? Would you like a bath now or after breakfast? So that we're offering the person some choices and not always dictating what's going to happen, as a means of being gentle and kind. In some situations, even a bathing chart could be printed and posted, and then gently referred to. Oh, it looks like it's Monday. It's time for us to get cleaned up today. Those can be opportunities to reduce the stress around bathing, and also trying to prevent the person from feeling so distressed or upset in the future. Often there's a misperception of information or past trauma that is revealed. So we're talking about a gentleman here who served in the military. He loves to watch war shows and movies on television. However, as his dementia is progressing, his wife is noticing that after he watched one of these programs, he is very agitated and insisting on joining a troop and is asking for his rifle. Is this a problem? What could be triggering it? How should the wife respond? And what might she do to prevent this situation from happening in the future? Well, let me say first here that weapons and dementia do not mix under any circumstances. While the person might have been quite capable and comfortable and effective in operating a gun before the disease, as the disease progresses and as even mild memory changes set in, this can be very dangerous. In this situation, the television show or movie could be triggering this behavior or reminding him of even past wartime situations or even traumatic experiences. So what we'd want to do is make sure that we gave away the guns to his son, or at the least remove all the ammunition, from the home. We really want to get rid of all ammunition. The wife could even join this journey, step into his reality and tell him that the colonel will be calling for him for backup when needed. We might in the future want to soften or remove that kind of television content, or alert him that that program isn't on right now. Maybe that it's even been canceled, so not telling the whole truth and everything but the truth all the time. Maybe it's that TV itself is becoming more overstimulating or confusing to him, as he's having trouble discerning the pictures and the voices and thinking it's really part of his reality. So we might be moving into more meaningful activities. Maybe music is going to be a much more effective intervention here. Or if he's got a lot of restless energy, taking a walk outside. Or maybe looking to the senior center or adult day program for some appropriate structured activities. Or even getting together with other veterans or old friends so that they can reminisce about those times in a healthier way without the distraction or misperception of a television. So we have a gentleman here who's sitting on the couch and is napping frequently during the day. This often happens, and I often hear family caregivers say he's very apathetic. He has no motivation. He's like a couch potato. And so what happens is this person ends up napping frequently throughout the day. And then the wife is maybe exhausted, and so we're going to bed early in the evening, and this gentleman is awake at 3 in the morning and is ready for work. Is this a problem? Sounds like it. It might be happening because he's having too much rest or snoozing during the day. What can his wife or care partner or daughter do to intervene in this situation? And how might he or she prevent this in the future? Well, we know our circadian rhythm or biological clock changes as we age. And it's certainly affected by dementia. It sounds to me, though, in this case, like the gentleman's not getting enough activity during the day. And so it's affecting his nighttime sleep. If he wants to go to work, we might say, that sounds like a good plan. We have a few hours before that shift begins. Why don't we relax with a cup of tea, a cup of decaf, or milk, whatever the person would enjoy, and find soothing. Listen to some quiet music in a recliner. So not forcing the person back to bed and not going against what they're saying in their own reality, which is, I have to go to work. Preventing the situation from happening might be offering more structure during the day, giving him more of a sense of purpose, offering rest periods if he seems tired, but making sure he's not napping for, 2 and 3 and 4 hours during the day, or sitting on the couch and snoozing while watching television. Because we want to promote more activity during the day so that we can promote better sleep at night. And you've probably heard this term before, sleep hygiene. We want to just be keeping the music and activity level alert and active in the morning. And in the evening, we're slowing things down, right? We're lowering lights. We're closing the shades to prompt the body and prompt the circadian rhythm of being aware that it's time for sleep. So often, made-up stories or delusions, false fixed beliefs occur as someone progresses through dementia, because when we don't know the right answer or we're upset or distressed and we can't figure out the reason for what's happening, our brain makes up stories. And so this is a woman who's been living with her son and family. Her husband died many years ago, and she's been living independently, and now she's developed dementia and it's progressed. So her son's asked that she live with him and his family. She's often heard telling stories to extended family members and friends that she's neglected by her son. All they do is leave me alone all day. They don't feed me. The food's terrible. They never take me anywhere. Even though the reality is that she's going to a day program during the day while her son is at work. She has meals with the family in the evenings. They take her to church, and they take her to family gatherings. But in her mind, they do nothing for her. Is this a problem? Why is it happening? What should the son do? And how might he and his family try to prevent this from happening in the future? Well, it certainly could be a problem for the family, because they might be personalizing these theories and these stories. They might be saying to her, what are you talking about? You go to the day program, the day club every day, and we always take you to church, and we make home-cooked meals for you in the evening. But in her mind, that's not her reality. So one thing they could do is alert other family members of these stories and how to address them politely so that they don't ramp her up or encourage her to get upset if that's not what's happening. Create a list of activities, maybe even a structured activity plan, and kind of show her and remind her, hey, these are some of the things we did this week, and we had a really enjoyable time. But more often than not, it's going to be important to really play on the emotion here. So her emotion is telling us that she's dissatisfied, or she doesn't feel connected, or maybe she doesn't feel like she has a lot of control over her own life. This is a woman who's always been very independent, lived on her own, and now is living with family, has had to adapt to their structure and their way of doing things. It's always good to take a very gentle approach. The son might remind her that he's so glad that she moved in with them, that it gives him a lot of pleasure to be around her, and that they really enjoy having her there. And they want her to feel as included as possible. Are there other things that she'd like to be doing that maybe she hasn't done yet? Or are there other things that they could do to make her feel comfortable instead of getting defensive? And maybe even validating her feelings. You know, I know it was hard for you to come and live with us, but we're really glad you're here. And we really want to enjoy the time that we have with you. Not recognizing familiar people. So a daughter visits her mom routinely, who's now in a memory care community. However, her mom is now believing that she's really her sister. Or sometimes she knows that she seems familiar but doesn't recognize who she is at all. Is this a problem? Could be. Whose problem is it? Probably the problem of the daughter, right? As she's experiencing pain in that her mom is not recognizing her anymore. Why is it happening? Because the short-term memory is fading. And so maybe she thinks that her daughter looks like her sister because maybe that's what her sister looked like at that age, right? So she's got the long-term memory she's reflecting on. This is a person who looks familiar. Maybe it looks like my sister. The important thing here is that the daughter not take it personally, and to recognize that her mom is always going to recognize that she's a familiar person who brings her comfort. So it's better for her not to take it personally, to remind herself that this is the disease, to go along with whoever her mom thinks she is at the moment, and to take comfort that she recognizes her as familiar and to go along with that. Not to scold her, test her, who do you think I am, or don't you remember I'm your daughter, is not going to be an effective method, right? It's important for her to always align with and be on her mom's side and to try to make things easier for her. So even though she visits and she's been her daughter for many years, she might show up and say, hey, Mom, it's your daughter Janine. I came for a visit. It's going to be much more helpful. Not to scold her, not to personalize, not to test her. And to remember that this is not her mom. This is the disease progressing. And to get some comfort for herself if she's having a hard time. Being a caregiver and watching the decline of somebody with dementia can be very painful. There's a lot of grieving that happens along the way. So talking to a trusted friend or going to a support group can be a very helpful way of getting support for yourself, but also from learning from other people who are experiencing something very similar about how they handled this when this happened in their family. So what do you do when everything else has failed? You've tried all of these interventions and what you're doing isn't working. When should you contact the medical provider? And I say medical provider here because that might be the person with dementia's primary care doctor. It could be a nurse practitioner or a physician's assistant. It might be a specialist that you're working with, maybe a neurologist or a geriatric psychiatrist. Really, often the behavioral interventions, I think, can minimize most challenges. But if you see a very abrupt change in behavior, mental status, or functionality in the person, so even though they have memory problems, all of a sudden those memory problems are looking very strange or different or accelerated. If you suspect that maybe your person's having pain or acting differently, maybe it's an infection, maybe it's a chronic condition like arthritis that's acting up and the person can't tell you it's pain. That's another good reason to seek help from a medical provider. If you suspect depression, maybe the person's tearful or more and more withdrawn, despite your efforts to get them to go along with you to an event or a program, they won't. Especially if you see that they're having hallucinations, so they're seeing, hearing things that aren't there. Delusions, so they're having false fixed beliefs that are really distressing to them or interfering with their day-to-day life. Maybe the person is so paranoid that they're not eating or drinking. Those would be situations you definitely want to address with the medical provider. If there's violence, so it's important for you to be aware of that. It's important for you to take care of yourself first as a provider or as a family caregiver, and to also recognize that that's not a comfortable place for the person with dementia. If everything else you've tried has not worked, seek the support of your medical provider. I think these are really good interventions to employ. If you want to learn more, we have many free monthly webinars and online classes on our website, and I really appreciate the opportunity to talk with you today. Thank you.